Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
So hi everyone, my name is Kathryn Kellohen. I'm a second-year pharmacy resident in emergency medicine at Stanford Healthcare. And today I'm presenting on the RAPID trial, self-administered intranasal Etripamil using a symptom-prompted repeat dose regimen for atrioventricular nodal dependent supraventricular tachycardia. So before we jump into the trial, I wanted to give a quick background of paroxysmal supraventricular tachycardia, also known as PSVT, which I will be referring to moving forward. So PSVT is a rapid heart rate. Generally, patients will have these intermittent episodes of SVT that really start and stop without any warning. And as you can imagine, this is very scary for patients. They often present with palpitations, sweating, chest pressure, feeling some sort of lightheaded or dizziness, fatigue, and anxiety. And this affects many patients within the US. And up to 25% of these who actually present to the emergency department end up getting admitted into the hospital. So the big issue that we face today in the US. Some demographics of PSVT include patients that are greater than 65 years of age. Oftentimes they're female, affects more Black patients than white patients. And some comorbidities that they present with are heart failure, diabetes, peripheral vascular disease, valvular heart disease, as well as chronic pulmonary disease. I wanted to mention that PSVT is different than other types of atrial tachycardias. So it's important to know it's not AFib, A-flutter, or sinus tachycardia, as it distinctly affects the AV node within the heart, usually due to a conduction issue within the AV node. In terms of management for PSVT, in the acute setting when a patient presents to the emergency department, we generally manage to attempt vagal maneuvers before utilizing other medications. And the vagal maneuvers include Valsalva or the carotid massage, are just two examples. And then if those don't work, we end up transitioning to the intravenous option. So patients will either be using diltiazem, metoprolol, or adenosine. And oftentimes we generally use adenosine most commonly for these symptoms that patients present with. And as we know, adenosine oftentimes will make patients feel a sense of impending doom. So it's important to note that for future visits. Additionally, if a patient is hemodynamically unstable, we will cardiovert them. In the chronic setting, we have maintenance medications such as oral beta blockers, oral calcium channel blockers, and oral antiarrhythmics. These two options are options for maintenance therapy, but they are difficult given that they need to be taken every day in order to suppress their PSVT. And some patients don't comply in taking some of these oral medications that for a condition that is very episodic in nature. Additionally, there's pill in the pocket for these medications, but the onset is slower and there's definitely side effects with these options and the efficacy is not as good compared to an intravenous option. Alternatively, there's catheter ablation, and not all patients prefer to have an invasive therapy done in order to treat their PSVT. And some patients may not qualify for it as well due to the frequency or duration of their symptoms. So again, there's a big gap in how we manage the chronic versus the acute phases where a patient ends up presenting to the emergency department. So that leads me to Etripamil, which is the drug of investigation. Currently, it's not FDA approved right now, but it is a 70 milligram nasal spray, how it was studied in the trial, with an optional repeat dose to repeat one time. So patients will self-administer this nasal spray, and it was designed for use to be outside of the healthcare setting. For its mechanism, it is a short-acting L-type non-DHP calcium channel blocker. It basically slows and prolongs the AV nodal refractory period by inhibiting calcium ion channel influx through the slow channels in the AV nodes. And just as a reminder, it's very similar to the mechanism of verapamil. In terms of pharmacokinetics, onset is about less than 10 minutes with a half-life of about 20 minutes. The max concentration generally reaches within your body about 7 minutes long. And it's very similar onset with the other agents available, maybe slightly slower, but again, comparable within the other agents available currently. In terms of previous literature, so the NODE-1 trial is their first phase 2 dose finding study. They completed the study in order to identify which is the safest and most efficacious dose They tested 4 different doses to identify the most optimal dose for SVT conversion into normal sinus rhythm compared to placebo. They ended up finding out that doses between 70 to 140 milligrams were statistically significant in converting from PSVT into normal sinus rhythm, anywhere between 65 to 95%, compared to 35% with placebo. And they identified that 70 milligrams was their ideal dose because other doses may have caused a transient drop in blood pressure. So that dose was chosen into the phase 3 trial. So the first phase 3 trial is the Node 301 trial. This is their part 1 of phase 3 trials. It was designed to be conducted outside of the healthcare environment in a medically unsupervised setting. They also included adults with a history of PSVT for at least 20 minutes or greater, and they compared placebo versus etripamil 70 milligrams. Their primary outcome was to demonstrate efficacy and safety at 5 hours of a primary outcome. They identified that there was no difference in efficacy at 5 hours, but these patients did tolerate the dose of 70 milligrams etripamil, similar to the Node 1 trial of what data that showed. So they ended up completing a post hoc analysis to look at the efficacy on different time points, and they actually found that there might be efficacy at 30 minutes. They saw that there was about a 50% conversion rate to normal sinus rhythm compared to 35% at placebo. So they thought maybe they overshot in terms of the time frame of what is most efficacious for the drug. So that leads us to the part 2 trial of the RAPID trial that I'm presenting today. So in regards to the RAPID trial, it is a multi-center randomized double-blinded placebo-controlled event-driven trial. It was conducted across Europe and North America from October 2020 to July 2022, and it was funded by Milestone Pharmaceuticals, which is the company that developed etripamil. Their hypothesis was that etripamil 70 milligrams with an optional repeat dose will demonstrate safety and efficacy of conversion from PSVT into normal sinus rhythm within 30 minutes of drug administration. So that's what their primary efficacy outcome is. It's the time to adjudicated conversion of confirmed AV nodal dependent PSVT into sinus rhythm for a minimum of 30 seconds within 30 minutes of drug administration. They also looked at safety outcomes for within a 24-hour time frame period. What adverse effects did the patients experience from this medication? What were their vital signs? Did they develop any arrhythmias or conduction disorders after receiving etripamil? Additionally, some secondary outcomes included time to conversion before and after 30 minutes, what % of patients required additional medical interventions if they had to return to emergency department in order to stop their PSVT episode. Additionally, 2 other outcomes were more patient-focused outcomes, so a treatment or a survey that was sent out to them assessing their happiness with the medication before and after based off their symptoms. So for inclusion criteria, it's very similar to the previous studies that I mentioned. Adults with a history of sustained PSVT for at least 20 minutes, and both males and females were required to utilize highly effective forms of contraception, with females demonstrating negative pregnancy tests upon every visit that they checked in on them. There was a large exclusion criteria within the study. Some of the main ones were hypotension at baseline, if patients had any allergies to verapamil, because again, the mechanism is very similar to verapamil. If they're on any current antiarrhythmics, they also excluded these patients. And if they have any, like a variety of cardiovascular conditions, these patients were also excluded from the study. In terms of statistics, based off their prior Node 301 study, it was determined that a 90% power to detect a 19% relative risk reduction treatment difference at a two-sided significance level of 0.05 would require a total of 180 patients in the efficacy arm of the study. So in order to have a minimum of 180 patients that had confirmed PSVT, there would at least need to be 500 patients within the study in order to have the 180 powered in the efficacy arm. Their primary outcome was analyzed with the Kaplan-Meier curve and hazards ratio with Cox proportional and Wilcoxon test for p-values, and secondary outcomes were exploratory, and they utilized ANOVA and the chi-squared test. So the study intervention is a little complex, so I wanted to break it up into these steps. So basically, they enrolled patients in the study. They tested to see if they were tolerating a test dose. They gave them 70 milligrams of etripamil 2 different times, 10 minutes apart, just to confirm that they actually tolerated the drug before randomizing them. If they did tolerate them, then they counseled them on various things. First thing is when they experienced symptoms of PSVT, they were required to put on an EKG, single lead EKG onto their body and start recording so that the electrophysiologist could further then look at the rhythms that the patients were experiencing. Then they were taught the appropriate vagal maneuvers for how to eliminate the PSVT. And then they were taught if they do need to administer the drug, how they would appropriately self-administer this medication to terminate the symptoms. And so then moving forward, if the patient does experience the perceived PSVT, they would give themselves the first dose. And again, if there were still symptoms within 10 minutes, they could repeat that dose within 10 minutes. And then if from the symptom onset, if it's been a total of 30 minutes and the patient still has not had symptom resolution, they were required to go to the emergency department and get managed there because they weren't being managed with their etripamil. And they were required to also continue wearing their EKG as the EKG was recording for a total of 5 hours. So looking at the methods, they initially screened 842 patients into the study. And after excluding patients who didn't tolerate the test dose or who didn't meet inclusion criteria, they randomized a total of 692 patients. But then after randomization, 437 patients ended up not having any PSVT episodes. So in total, there were 255 patients with PSVT episodes that were randomized into the study. This leads us to placebo group on the left, etripamil group on the right. This is the safety population. So again, wanted to emphasize that this is the population of patients included in the safety because they received the placebo or etripamil due to the fact that they thought they may have a PSVT episode. This does not mean that it was a confirmed episode of PSVT. So again, the safety analysis was similar to an intention to treat group. And then there's an efficacy arm as well. And these are the patients that did have confirmed PSVT upon review based off the 4 to 6 electrophysiologists that reviewed the data afterwards and confirmed that they actually did have PSVT. And they confirmed that the patients didn't spontaneously terminate or with vagal maneuvers, make sure they fell appropriately into this bucket. I also wanted to emphasize the difference between this study and the old study is that they had the option to repeat their dose. And so you can see in the placebo group, 79% of them ended up taking that second dose of the study drug. And then 66% of the etripamil group ended up taking that second dose of the study drug. So these are the baseline characteristics among patients, which are for the most part very evenly distributed across placebo and etripamil. The average age of patients was about 50 years old. Majority of the patients were female within the study, and majority of the patients were white, about 90% of them. And the average weight was about 80 kilos for these patients. And at the time, most of them were either on a beta blocker or a calcium channel blocker. You can see greater than 60% of each group were at least on one or both of these medications. In regards to the primary outcome, again, this was assessing conversion of PSVT into normal sinus rhythm for a minimum of 30 seconds at 30 minutes. So just to orient you to this graph, on the y-axis, we have the conversion rate in percentage, and on the x-axis, you have time in minutes. And then the blue line is the placebo group, and the red line is the etripamil group. And so you can see at 30 minutes, the furthest time point on the graph on the x-axis on the right, you can see that etripamil had a 64% conversion rate compared to placebo, which had a conversion rate of 31%. And this result was statistically significant with a hazards ratio of 2.62. Similarly, they reconducted this at 5 hours since they did have that data of EKG recordings into 5 hours. So you can see, again, this graph is oriented exactly the same. At 300 minutes, which is 5 hours, about 82% of patients in the etripamil group had conversion into normal sinus rhythm, and 69% in the placebo group had conversion to normal sinus rhythm. But again, this result was statistically significant with a hazards ratio of 1.7. And this graph is showing the specific time points to conversion. So you can see, again, the X and Y axis are very similar. Red line is etripamil, blue line is placebo. You can see at halfway time point, 17 minutes median time to conversion for etripamil compared to placebo of 53.5 minutes for a median time to conversion, which demonstrates that etripamil had about a 36-minute conversion, or it was about 36 minutes faster for conversion compared to placebo to normal sinus rhythm. This forest plot for their primary outcome just breaks down some of the variables that they had. that they looked at. So the data points on the right suggest that etripamil is preferred than placebo. I wanted to highlight specifically that they show that the age group of less than 70 may benefit more so with etripamil compared to placebo. Additionally, they also mentioned that if the symptoms had been 30 minutes or less than 30 minutes or greater than 30 minutes, both groups would benefit from etripamil. So it seems to be that whether it's early or late in terms of their symptom presentation, there seems to be benefit in administering this medication. One of the secondary outcomes was the patient-centered patient global impressions of improvement, the 7-point scale. So basically at baseline, these patients were asked to rate their symptoms. So you could see rapid pulse, palpitations, feeling dizzy or lightheaded, shortness of breath, or anxiety. The baseline symptoms were very similar across groups. So about 80% for rapid pulse in placebo and etripamil. And you can see that they're very similar across both groups at baseline. However, on the right side, this is the responders group. And so these patients ended up reporting that their symptoms improved in these groups. So you can see that the rapid pulse, palpitations, feeling dizzy or lightheaded, shortness of breath, or anxiety were actually significantly higher or improved within the etripamil group based off this self-reporting scale. So the patients did report improvement in their symptoms. And I wanted to, again, explain that this is exploratory. Some other safety events that were looked at were analyzed for 24 hours after obtaining etripamil, and they found that the safety outcomes were really localized to study drug administration. You can see that they are higher in the etripamil group compared to placebo, so nasal discomfort, nasal congestion, rhinorrhea, and epistaxis were all higher in the etripamil group, but again, very local side effects for these medications. In terms of alternative safety events, they included EKG readings. Again, they measured for up to 5 hours afterward, and there was no differences compared to placebo of any developments of any different tachycardias or heart blocks or recurrence rates, AFib, etc. So this suggests that etripamil is safe in terms of new developments of arrhythmias, as it did not show that there was a difference. So in summary, the primary efficacy outcome showed that they did confirm that there was conversion of AV nodal dependent PSVT for a minimum of 30 seconds within 30 minutes at 64% with etripamil compared to 31% with placebo, with a hazards ratio of 2.62. And this, again, this result was statistically significant. I wanted to mention with this primary outcome, the number needed to treat was 3. So for every 3 patients treated with etripamil, 1 of them will convert to normal sinus rhythm, which is a pretty good number needed to treat. In terms of their safety outcomes, it was higher locally in the etripamil group with nasal discomfort, nasal congestion and rhinorrhea and epistaxis and some dizziness. But again, mostly very localized symptoms to the study drug administration. In regards to secondary outcomes, again, these outcomes were exploratory, but there was really no difference with many of their outcomes. So time to conversion before and after 30 minutes, as well as patients who ended up having to go to the emergency department to terminate an episode of PSVT, there was no difference between them. In addition, the TSQ-9 and the PGI, the questionnaires for patients on how satisfied they were in regards to their treatment, may have suggested that etripamil is preferred over placebo, but again, this was exploratory. So overall, the author conclusion is that etripamil nasal spray is superior to placebo for rapid conversion of sinus rhythm, and it is well tolerated in patients that have sustained PSVT. So some strengths of the study, I think it's a well-designed study. Their methodology is very clear in terms of how they trained patients and everything is laid out step by step. I think that the fact that they conducted their phase 3 study after their Node 301 phase 3 study did not demonstrate efficacy. And instead of changing their study design halfway through their study, they ended up completing that study with a lack of confirmed or a lack of efficacy in their outcome, but they reconducted it to find a different outcome that might be efficacious. And the safety in the perceived and confirmed PSVT group, I think, was interesting because in real life, if this drug does get approved, these patients will probably be administering this medication even in non-PSVT episodes. So it was nice that they still included the patients in the safety analysis that did give themselves this medication, even if they didn't actually have PSVT. So there was no alarming side effects with that. They also did reach statistical power. So like I mentioned, they needed to have at least 500 patients in the study in order to meet the minimum of 180 patients with the number of events. And so they did have 184 patients in their efficacy group, so they did reach power. Additionally, it's a novel PSVT drug. Like I mentioned, there's a lot of barriers in how we manage PSVT currently, and maybe this will offer a capability in pre-hospital care, as well as maybe one day it'll enter the RED, and maybe if patients have difficult IV access, we can be utilizing this medication for them. And it does offer an alternative to adenosine. Again, like I mentioned, the impending doom that patients experience, they may not want to repeat that dose. So it's another option. And again, if a patient doesn't have to come into the emergency department or get admitted for their condition, this would really help decrease some of those healthcare costs. Some limitations of the study: it is funded by the drug manufacturer, but it is the study for approval, so there's not really a way to avoid that. There's only 135 patients within the etripamil group, and as we know in cardiology literature, oftentimes the trials are a lot larger in terms of the N in the trials. Also, these are some of the secondary outcomes, and they weren't necessarily powered to detect any differences in if there was a difference in the emergency department visits, if it was actually better in the etripamil group compared to placebo. Additionally, the single versus the repeat dose, it's not clear if there's a difference in efficacy between the two. Also, the single lead EKG. We know that the standard of care for diagnosis for PSVT is a 12 lead EKG. It's not as accurate using a single lead EKG. I think, for example, even like looking at ST segment elevation, I think there's like a 44% sensitivity with a single lead EKG compared to 80% with a 12 lead. So pretty different in terms of accuracy. In terms of diagnosis from PSVT to etripamil, these patients oftentimes had about like a 2-year time since diagnosis to using etripamil. So we're not really sure how this can apply to patients that may have a more refractory PSVT for like 10 years, for example. And also in the forest plot, I mentioned that the greatest benefit might be in patients of less than 70 years old. And again, the baseline characteristics suggest that PSVT really affects patients that are 65 years or older. So not a huge time window in benefit for patients. Population is primarily white. I mentioned over 90% of patients in the study were white, but for the race, it seems that Black or African American patients are more affected than any race for PSVT. Additionally, we don't know the comorbidities of the patients within the study, so it's hard to apply this in a real-world population. So just some take-home points. Etripamil does demonstrate safety and efficacy in patients with PSVT within 30 minutes for a minimum of 30 seconds. I think it is a useful application if this is FDA approved, when patients are properly educated on how to use etripamil. It could overall really save a lot of money in terms of patients and healthcare costs. It is a novel medication for PSVT and would be designed to be utilized in the pre-hospital setting. But again, like I mentioned, maybe one day it'll be used within our emergency departments as well. And I think overall it does require more safety data in a larger trial. But at this time, if this were to get FDA approved, I would opt to use this medication because of the alternatives currently of how we manage this medication. And I think it fills that gap in care currently in this day and age. And these are my references, and I will take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only. It does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.